In this video, we will go from simple ECG criteria of premature ventricular complex to the management of premature ventricular contraction-induced cardiomyopathy, so you can use the time codes to check the most relevant information for you. Let's go. According to the current guidelines of European Society of Cardiology, premature ventricular complex or PVC is characterized by premature occurrence of abnormal QRS complex. Therefore, the ECG criteria of PVC are: the first one is premature occurrence. The second criteria is abnormal QRS complex, which is characterized by a QRS duration greater than or equal to 120 milliseconds. Corresponding T wave is broad and has the opposite direction to the major QRS deflection. In other words, discordant T wave. And the last criterion is absence of P wave before PVC. Now let's find all of these criteria one by one on real ECG example. To check the premature occurrence, let's define the place where the next normal sinus QRS should be located. For this, measure the interval between the beginnings of QRS complex during the sinus rhythm. Now we see clearly that our QRS occurs earlier than predicted QRS, so the first criterion is present. The QRS duration is 160 milliseconds. T wave is broad and pointed in opposite direction to the QRS complex, so T wave is discordant. Therefore, the second ECG criterion is present. And the last criterion: there are no P wave before premature ventricular contraction. Few mechanisms can cause premature ventricular contractions. There are abnormal automaticity, reentry, and triggered activity, which includes the early and delayed after depolarizations. Normally, the sinus impulse is going through the conduction system. It defines the morphology of normal sinus QRS, but in case of PVC, impulse arises somewhere in the ventricles and spread from the site of the origin to the rest of the ventricles by another than normal path. So different sites of PVC origin mean different paths of the impulse in the ventricles, thus different QRS morphology. Therefore, the site of origin of PVC defines the morphology of QRS complex. If the premature ventricular complex has right ventricular origin, the QRS shows the left bundle branch block morphology, because the right ventricle is excited first and the left ventricle is excited after the right ventricle, like in the case of left bundle branch block. So the opposite situation occurs if the site of origin of PVC is the left ventricle. In this case, QRS has right bundle branch block morphology. PVC localization is important because it defines the management strategy, which we will discuss later in this video, so therefore let's go deeper into localization. Approximately 2/3 of all PVC is located in outflow tracts of the ventricles. In turn, the outflow tract is the ventricle portion through which the blood passes to enter the great arteries. According to this, right ventricular outflow tract PVC is characterized by left bundle branch block morphology and inferior mean QRS axis. At the same time, left ventricular outflow tract PVC is characterized by right bundle branch block morphology and inferior mean QRS axis. Different articles can help you evaluate the site of origin of PVC. Here and in the description of this video, I left resources that I usually use on everyday basis to check the PVC site of origin. Now let's describe the type of PVC and PVC terminology. If PVCs have the same morphology, it means it has the same site of origin, thus they called monomorphic or unifocal. Different morphology suggests a different site of origin. This PVC is called polymorphic or multifocal. When PVC interrupts the T wave of previous sinus impulse, it is called short-coupled. Should be noted that short-coupled PVC can act as a trigger for polymorphic ventricular tachycardia that in turn can be fatal. Two consecutive PVC called couplet. More than 3 consecutive PVC with a heart rate more than 100 beats per minute defines the ventricular tachycardia. Ventricular tachycardia is non-sustained if it lasts less than 30 seconds. If ventricular tachycardia lasts more than 30 seconds or requires intervention for termination, it is called sustained ventricular tachycardia. If we have 3 or more consecutive PVC complexes with a heart rate less than 100 beats per minute, we call it idioventricular rhythm. Usually, idioventricular rhythm has a heart rate less than 40 beats per minute. If it has more than 40 beats per minute, this type of idioventricular rhythm called accelerated. A situation when every second complex is PVC, called ventricular bigeminy. A situation when every third complex is PVC, called ventricular trigeminy. And every fourth ventricular quadrigeminy respectively. One of the basic ECG characteristics of PVC is the coupling interval, which defines as a distance between the onset of preceding sinus QRS and that of the premature beat. Here we have preceding sinus QRS, so let's define the starting point of the coupling interval. The finish point for the coupling interval will be the beginning of PVC. Coupling interval can be fixed when it is equal or almost equal in different PVCs, like in the example. Coupling interval can help to suggest the pathophysiologic mechanism of PVC. If the PVC have the same morphology, other words, they are monomorphic. Together with the fixed coupling interval, it suggests the reentry or triggered activity mechanisms. Sometimes PVC have the variable coupling interval, when the difference is more than 100 milliseconds. In this case, if the PVC is monomorphic, together with variable coupling interval, it suggests the abnormal automaticity as a possible underlying mechanism. Variable coupling interval is one of the criteria of ventricular parasystole. By the way, we have another video about it. Variable coupling interval in polymorphic PVC, explained by the different site of origin. Now let's describe the compensatory pause. But firstly, we defined post-extrasystolic interval as a distance from PVC to the next normal sinus beat. Both the coupling interval and post-extrasystolic pause form compensatory pause. If the compensatory pause is equal to 2 normal RR intervals, it is called complete compensatory pause. In the vast majority cases of PVC, compensatory pause is complete. Let's explain how the compensatory pause forms. For this we will use a schematic picture of conduction through the atria, AV node and ventricles. Normal sinus impulse goes faster in atria and ventricles, so we draw the vertical line, and goes slower in AV node. As a result, the line is inclined. The red zone is the refractory period of AV node, when it can't conduct any impulses in any directions. Therefore, when the PVC occurs, we mark it as red lines. It can't be conducted retrogradally to the atria due to the refractory period of the AV node. While the PVC occurs in ventricles, sinus node starts to prepare the next sinus impulse, like the charging of the battery. But the next sinus impulse also finds the AV node in refractory period, so it can't be conducted to the ventricles. But the sinus node again starts to prepare another impulse, and this one reaches the AV node after the termination of the refractory period, so it easily conducts to the ventricles. P wave from the sinus impulse which was not conducted can be found in ST segment or T wave of the PVC. So 2 full charging time of sinus node explains the duration of complete compensatory pause, which is equal to 2 normal RR intervals. But sometimes situation is changed and compensatory pause is incomplete. The first and the second sinus impulses conducts as usual, after PVC occurs, but PVC impulse reaches the AV node beyond the refractory period, So PVC impulse retrogradally conducts to the atria that we see as a negative P wave in the second, the third and AVF leads. P wave is located after the QRS complex of PVC. In this situation, PVC impulse reaches the sinus node just during the preparation of the next impulse and discharges it before it fully charged. So the sinus node must start preparing the next impulse from the bottom. Thus in this case, the compensatory pause is equal to one full charging and one interrupted. Therefore, it is less than 2 normal RR interval and called incomplete. The next type is interpolated PVC, which has no compensatory pause at all. As in our case, the compensatory pause almost equal to the 1 RR interval. So, first two sinus complexes are absolutely normal. Interpolated PVC is retrogradally conducted to the AV node, but it is not able to completely penetrate it. This phenomenon is called concealed conduction. This concealed conduction increases the refractoriness of AV node, causing a subsequent AV nodal conduction delay. Therefore, the next sinus impulse conducts slower through the AV node, which results in PR interval prolongation. The last sinus impulse passes AV node without any conduction delay. This is called concealed conduction because we see only outcomes of this phenomenon as PR prolongation in the next sinus impulse, but not the phenomenon itself. Interpolated PVC is important for PVC-induced cardiomyopathy, which we will describe later. P wave and PVC. As you already know, PVC is not preceded by the P wave, because the PVC-related depolarization starts in the ventricles only. But as we already mentioned, the sinus P wave can be hidden in PVC complex in case of complete compensatory pause. Or retrograde negative P wave can be present after PVC QRS complex in case of retrograde conduction of PVC impulse to the atria through the AV node. But it is really rare condition. But sometimes we see the sinus P wave just before the PVC. It occurs when the PVC arises later. In this case, sinus impulse have enough time for the atrial depolarization, but not AV nodal and ventricular depolarization due to PVC arising. So PVC impulse can't pass through the AV node due to the sinus impulse related refractory period, and sinus impulse can't pass through the AV node due to PVC. PR interval between the sinus P wave and PVC is shorter than in regular sinus rhythm. Now look at this example. Here we see the sinus complexes and PVC. But also we see the complex that has P wave and partially looks like PVC in V1 and AVF, but with a smaller amplitude, and partially looks like the sinus in V5, but slightly another. So this complex has morphology between the sinus and PVC. This type of complex is called fusion bits. During the fusion bits, part of the ventricles depolarized by the sinus node, another part by the PVC. Result: QRS with intermediate morphology between the sinus and PVC. It occurs if the sinus impulse has enough time for the beginning of ventricular depolarization, but in this moment PVC occurs. This is why QRS complex has intermediate QRS morphology between the normal morphology and PVC. Management of PVC according to European Cardiology Society Guideline 2022. Patients who have PVCs with no apparent structural heart disease, which means lack of significant abnormalities in physical examination, basal ECG and echocardiogram. So, if there is no structural basis for the PVC, we call it idiopathic PVC. After this, check the presence of symptoms of PVC. Symptoms should be relevant and related to PVC, for example palpitation feeling. If yes, check the site of origin of PVC. If it is right ventricular outflow tract or left ventricular fascicles, parts of the left bundle branch, catheter ablation is recommended, or beta blockers or flecainide should be considered. If site of origin of PVC is another than right ventricular outflow tract or left fascicles, beta blockers or calcium channel blockers are recommended, or flecainide or catheter ablation should be considered. If PVC causes no symptoms, but the amount of PVC is more than 20% of all contractions during the monitoring period, regular follow-up of left ventricular ejection fracture is recommended, or catheter ablation may be considered. The percent of the patient's heartbeats that are PVC is definition for the PVC burden. For the calculation of PVC burden, you need the total amount of PVC during the monitoring period, usually 24 hours, divide by the total amount of contraction and multiply by 100%. PVC burden will play an important role in the development of PVC-induced cardiomyopathy. If the PVC burden more than 10%, regular follow-up is recommended. If it is less than 10%, management is not needed. But in the case of new symptoms or changes in patient's clinical condition, re-evaluation should be considered. Let's describe the clinical meaning of PVC. When the premature ventricular complexes is associated with structural heart disease, clinicians should always be alert because there is an extremely high risk of ventricular tachycardia and ventricular fibrillation, which can lead to sudden cardiac death. But when the PVCs are not associated with structural heart disease, it can cause left ventricular dysfunction and premature ventricular complex-induced cardiomyopathy. PVC-induced cardiomyopathy, defined as a secondary and reversible cause of left ventricular dysfunction in patients without structural heart disease. By the way, in patients with structural heart disease, frequent PVC can aggravate off-existed left ventricular dysfunction. But how does the PVC lead to left ventricular dysfunction? The mechanism of left ventricular systolic dysfunction have yet to be elucidated, but possible mechanisms are desynchronous ventricular contraction, alteration in ventricular calcium level, and alteration in heart rate dynamic and hemodynamic parameters. Desynchronous ventricular contraction caused by abnormal ventricular activation during PVC, similar to left bundle branch block or ventricular pacing. Look at the short axis view of echocardiogram of the normal left ventricle contraction. A perfectly rounded shape means perfectly synchronous contraction of the left ventricle. Premature ventricular contraction results in a form of electromechanical dysynchrony by causing a sequential instead of normal parallel activation of the myocardium. So we see not a perfectly rounded shaped but deformed. Desynchronous contraction is less efficient than normal and can lead to systolic dysfunction. Alteration in intracellular calcium. Look at the graph. During the regular sinus beats, contraction force is normal and equal to 100%. But when the premature ventricular contraction occurs, contraction force in this beat rapidly decreases to 20%. Due to less amount of calcium released from the sarcoplasmic reticulum because of refractory period in parts of ryanodine receptors. But in sinus beat which follows the premature ventricular contraction, force becomes even higher than 100%. Because less amount of calcium which released during the PVC means that more calcium remains in the next sinus complex, more uptake of calcium in the sarcoplasmic reticulum and ryanodine receptors which are recovered from inactivation. All of these changes in contraction force lead to increased oxygen consumption by the myocardium and systolic dysfunction. As a result, some of PVCs do not generate enough ejection volume or pressure to allow the opening of aortic valve and not strong enough to make detectable aortic pressure, mechanical systole, leading to concealed mechanical bradycardia. Systole just does not occur. In this case, the cardiac rate measured on ECG does not reflect the true mechanical cardiac rate. Repeated mechanical inefficiency of PVCs leads to sustained concealed mechanical bradycardia, which in turn lead to systolic dysfunction due to decreasing of cardiac output, increasing of left ventricular diastolic pressure, leading to volume overload and left ventricular dilatation. But how much PVC should be present to cause the left ventricular dysfunction? So we again come back to premature ventricular contraction burden, the percent of the patient's heartbeats that are PVC. Should be noted that premature ventricular contraction burden is the strongest independent predictor of PVC-induced cardiomyopathy. On the other hand, interpolated PVC, which were discussed earlier, are associated with the cardiomyopathy independently of increasing PVC burden, because interpolated PVC can increase the overall heart rate. The minimal PVC burden threshold for the development of premature ventricular contraction-induced cardiomyopathy is 10%. If the PVC burden is more than 10% and left ventricular ejection fraction is mildly reduced or reduced, structural heart disease should be checked. If the left ventricular dysfunction is explained by the underlying structural heart disease, it is not the PVC-induced cardiomyopathy. If it is not explained by underlying heart disease, it means that PVC aggravates the structural heart disease. Thus, catheter ablation or amiodarone should be considered as a management strategy. If there is no known structural heart disease, coronary artery disease, valvular disease, or inflammatory disease should be suspected, and further evaluation is needed according to the most likely diagnosis. If there are no suspected structural heart disease, cardiac magnetic resonance should be considered. If the late gadolinium enhancement is detected, it is favors the structural heart disease. If the late gadolinium enhancement is absent, we suspect premature ventricular complexes induced cardiomyopathy. In this case, catheter ablation is recommended, or antiarrhythmic drugs should be considered. If you like the content, press like and subscribe buttons and have a good day!